Hello everyone. So we are going to start stomach disorders. Firstly, we will cover acute gastritis. Acute gastritis is a transient mucosal inflammatory process that may be asymptomatic or may cause variable degree of epigastric pain, nausea, and vomiting. In more severe cases, there may be mucosal erosion, which may lead to ulceration that may cause hemorrhage and hematemesis and melena, or rarely massive blood loss. So normal gastric lumen is strongly acidic, with pH close to 1. That is more than million times more acidic than that of blood. This harsh environment, it is necessary for digestion, but it may cause damage to the gastric mucosa. So there are many or multiple mechanisms that have evolved to protect the gastric mucosa from this acidic pH. So coming to the mechanisms of gastric injury and protection. This diagram illustrates progression from mild form of injury to ulceration that occur with acute or chronic gastritis. So ulcer is formed due to gastritis, long-standing chronic gastritis or acute gastritis. So on the left hand side, this photograph, this is the normal mucosa of stomach covered with the mucus secreted by the epithelial mucus cells, superficial mucus cells. So normally the damaging forces that contribute to the ulceration or gastritis are gastric acidity and the peptic enzymes. And the defensive forces are surface mucus secretion, bicarbonate secretion into the mucus, mucosal blood flow, apical surface membrane transport, epithelial regenerative capacity, and prostaglandins. So defensive forces are mucus secretion, bicarbonates, blood flow, apical surface membrane transport, prostaglandins, and regenerative capacity of epithelial cells. So when there is injury to these epithelial cells or mucosa, either by H. pylori infection, it is the most common cause of chronic gastritis that will lead to ulcer. So injury due to H. pylori infection or due to NSAIDs or aspirin, cigarettes, alcohol consumption, gastric hyperacidity may lead to injury, and duodenal gastric reflux. It will cause increased damage and impaired defenses. Impaired defenses due to delayed gastric emptying or ischemia, blood flow will decrease, shock that will cause impaired defenses, and increased damage due to injury that will lead to loss of mucus that is normally present over the surface epithelial cells, mucosal cells. So the defense is lost. It will lead to ulcer formation. The mucosa is damaged, whole of the mucosa is damaged, and this ulcer bed, it is comprised of necrosis, necrotic debris, then inflammatory cells, acute inflammatory cells, then granulation tissue. You are seeing the blood vessels, inflammatory cells and fibroblasts forming granulation tissue. After that, fibrosis or scar formation. So, ulcer bed, it is comprised of necrotic debris, inflammatory infiltrate, granulation tissue and fibrosis. So, how you will remember? NIGS, N-I-G-S. Ulcer bed is formed by necrotic debris, then inflammatory infiltrate, then granulation tissue and scar or fibrosis. The mild acute gastritis may be difficult to recognize histologically since the lamina propria shows only moderate degree of edema and slight vascular congestion. The surface epithelium is intact. Only scattered neutrophils may be present along the epithelial cells or within the mucosal glands. So, microscopically, the mucosal surface epithelium is intact. Lamina propria will show slight degree of edema and slight vascular congestion. If there is presence of lymphocytes and plasma cells, it will suggest chronic disease. If neutrophils are present above the basement membrane in direct contact with epithelial cell, is abnormal in all part of the GIT and it signifies active inflammation. So, if lymphocytes and plasma cells are present, then chronic gastritis, chronic disease. If neutrophils are present in direct contact with epithelial cells, then it is active inflammation. Neutrophils are acute inflammatory infiltrate, but we are using term active inflammation. We prefer active inflammation over acute inflammation because active inflammation may be present in both acute and chronic states. So that's why if neutrophils are seen, then active inflammation. With more severe mucosal damage, erosions and hemorrhage may develop. Erosion, it denotes loss of superficial epithelium generating a defect in the mucosa, and that is limited to the lamina propria. So when there is loss of superficial epithelium limited to lamina propria, it is accompanied by neutrophilic infiltrate within the mucosa and fibrin containing purulent exudate in the lumen. So erosion, it is loss of superficial epithelium generating a defect in mucosa and limited to lamina propria. And there is neutrophilic infiltrate also. Hemorrhage cause dark punctate in an otherwise hyperemic mucosa. Will cause dark punctate. This concurrent erosion and hemorrhage is termed as acute erosive hemorrhagic gastritis. So, acute gastritis is termed when lamina propria shows mild edema and vascular congestion only. The surface epithelium is intact. And chronic disease when lymphocytes and plasma cells are seen. Active inflammation when neutrophils are present above the basement membrane that are coming in direct contact with epithelial cells. And acute erosive hemorrhagic gastritis when erosion and hemorrhage is seen. there is loss of superficial epithelium. When erosion extends deeply after lamina propria or in the muscularis propria, they may progress to ulcers. Now, acute gastric ulceration. Acutely developing gastric mucosal defects are well-known complication of Nasal. They may also appear after several physiologic stresses. Some of these are given specific names based on location and clinical association. So, stress ulcers are most common in individuals with shock, sepsis, and severe trauma. Curling ulcers, they occur in proximal duodenum and usually associated with severe burns or traumas. Then Cushing ulcers, they are seen in persons with intracranial diseases. So, pathogenesis of these ulcers, NSAID-induced ulcers are basically related to cyclooxygenase inhibition that will prevent the synthesis of prostaglandins, which enhance bicarbonate secretion and inhibit acid secretion and promote the mucin synthesis and increases the vascular perfusion. So, the defensive mechanism is lacking, that will lead to ulcer. The lesions associated with intracranial injury, they cause the ulcer by direct stimulation of vagal nuclei, causing the hypersecretion of gastric acid. So, increased gastric acid, that will damage the mucosa. Hypoxia, reduced blood flow caused by stress-induced splanchnic vasoconstriction. When stress is there, it will induce the vasoconstriction. That will cause hypoxia and reduced blood flow, which will further lead to acute ulcers. Acute gastric ulcers may range in depth from shallow erosions to deeper lesions. They are rounded and are less than 1 centimeter in diameter. The ulcer base is frequently stained brown to black by acid digestion of extravasated blood and may be associated with transmural inflammation and local sinusitis. Acute stress ulcers are found anywhere in the stomach. Microscopically, they are sharply demarcated and there may be sufficient of blood into the mucosa and submucosa and inflammatory reaction will be seen. Conspicuously absent are the scarring and thickening of the blood vessels that are characteristic of chronic peptic ulcers. So, scarring and thickening of blood vessels is absent. Only sufficient of blood in mucosa, submucosa and inflammatory infiltrate will be seen. Now, complications of gastric ulcers. Gastric ulcer will cause bleeding. It occurs in 15 to 20% of the patients. It is most frequent complication and is life-threatening. It may be the first indication of an ulcer. Then perforation may occur in 5% of the patients after ulcer and it accounts for 2/3 of ulcer deaths. It is rarely first indication of an ulcer. Chronic ulcers may cause obstruction secondary to edema or scarring, and it is common it occurs in 2% of the patients. Most often, it is associated with pyloric channel ulcers or duodenal ulcers. It causes incapacitation, crampy abdominal pain, can rarely cause total obstruction and intractable vomiting. That's all of acute gastritis. Thank you.